Good evening, everyone. I am Ashish, Vice President with Zydus, and I welcome you all for this evening webinar, Pink Connect, Updates on HER2-Positive Breast Cancer. And it's our privilege today that we have eminent oncologists across the country and also a global authority on breast cancer for this evening webinar. Before we set the ball rolling for the scientific discussion, I'll take just a few minutes from all of you to share some important update from the organization. As an organization, in last 2 decades, we have moved strength to strength on the biosimilars, and the journey which started in 1996 from simple proteins has now moved to monoclonal antibodies and to also the complex moieties, which we would share in just a few minutes. 2020 was a landmark year for us where not only just the biosimilar on monoclonal antibodies, we also had the opportunity to introduce the first new biological entity from an Indian company, which was Tinrab. It's a cocktail of monoclonal antibodies used for rabies. And that was a milestone where, as an Indian company, we could also introduce a novel biological entity. But then from there, we have also moved to the next step of introducing the first ADC biosimilar in the world. Coming to the topic of interest today evening, when we talk about the HER2 landscape, trastuzumab access in last 1 decade has improved year on year. And when we talk about 2011, the access of trastuzumab was just 6%. And in 2020, if we look at the access of trastuzumab, it has almost moved to 50%. And we as an organization has also contributed significantly in that, as Vivitra, our biosimilar for trastuzumab, has contributed almost 1 out of every 4 patients in last few years. And in 6 years, we have touched 10,000 lives with the help of clinicians in the country. But when we talk about the TDM1, the drug which we discussed a lot today evening, the access story has not been great. Since 2015, the drug has been available in India, and few have been able to have access to it. And as per the data available, the access has been less than 5% till the biosimilar got introduced. And we are happy to share that now, as we talk to you, it's been 3 months that the TDM1 biosimilar is available in India through Zydus. And it has taken us 7 years, over 3 years of stability data, 25 biosims to say that it is biosimilar. And with all this effort today, Ujvira, the brand of TDM1 biosimilar, is available in the country. And these 7 years, year on year, we had to do a lot of work through our research scientists to make sure that the drug got into the Indian market. And the most significant step was in the year 2018, when the first ADC facility was developed in India. As these ADC cannot be developed in the biosimilar facility, a separate ADC facility had to be built in, which we did in 2018, and then it was possible to introduce the ADC biosimilar. So these facilities came together from Zydus to develop the first TDM1 biosimilar, and the most notable out of this is the ADC facility, as I said, where the conjugation of trastuzumab or Vivitra happens with the linker, and then the TMCC combines with the DM1 to make TDM1, and this TDM1 conjugate is then transferred to the Goa facility to make the final lyophilized product. And we have ensured that the Ujvira is developed indigenously with the totality of evidence approach, and not just on the comparable analysis on the amino acid sequence and the peptide mapping. The various assays have ensured that the drug distribution, the drug antibody ratio, the purity levels are as similar to the reference product. And these various assays were presented to the regulators before the phase 3 study approval happened. And post the phase 3 study, the drug got introduced into the country. So very happy to share that today we have an accessible option for TDM1 in India. And that's the access points which now the clinicians in India know about it. And this is 80% lesser price than the reference product. And the 6 cycles of the reference product today is equivalent to the 36, 37 cycles of Ujvira. So many more patients today are able to have access to it. And this is the snapshot of 90 days Ujvira has been into the Indian market. As I said earlier, the access to TDM1 was less than 5%. But now in 90 days, with the trust of clinicians in India, the data which was there with the clinicians, we have over 600 patients in these 90 days. That also reflects that in this year, probably the excess of TDM1 in India would move from 5% to 30%. With that access being laid out, now it's time to move to the scientific discussions of today evening. And I have the opportunity and privilege to introduce the program director of today evening, Dr. Raja. Dr. Raja needs no introduction, but I'll just take a few seconds to introduce her. Sir is Senior Consultant Medical Oncologist at Apollo Cancer Hospital, Chennai. Sir has received numerous awards and recognitions in his illustrious career. To name one, he has also been awarded as the Best Doctor Award by the Tamil Nadu MGR Medical University. He has special interest in the solid malignancies, and his life has actually been dedicated in improving clinical outcomes for the cancer patients, a clinician's par excellence, and a teacher known to many in the country. With that, sir, I'll pass on the session to you. From here, sir, if you can take the session forward.
Thank you, Mr. Ashish. Thank you for your very kind introduction. I thank the Zydus for inviting us all to be here and putting us all together for this exciting evening. And we have a very packed agenda today. And as we know that in HER2 positive breast cancer, currently there has been a tremendous increase in the work and the availability of the various molecules that are targeting the HER2 breast cancer. And much has been done both in the metastatic setting and also in the early breast cancer setting. And, once these drugs got themselves established in the metastatic setting, now the focus is really to see how to improve the outcome in the early breast cancer setting also. And today we have, very, very thoughtfully aligned agenda. We have two interesting speeches today, one from our Indian colleague, Dr. Dattatreya, and one from our eminent international colleague, Professor Charles Dyer. But the session is going to be chaired by two of the most eminent oncologists in the country, Professor Dr. Suresh Advani and Professor Dr. Sudeep Gupta. Professor Advani, does not need any introduction, and just to say a few words about him, he is an institution in himself, as all of us know, and he worked as the chief and head of the medical oncology for more than 30 years at the Tata Hospital in Mumbai, and he has touched the lives of more than 20 lakhs, that is 2 million people as patients in his service, which has spanned over 5 decades of oncology work. And he is synonymous for the word hope. And we all agree that he is one of the most important pioneers of oncology in the country, and he is a father figure for all the medical oncologists in the country. His work has been recognized by numerous awards. The most important ones to be mentioned are the Harvard Medical International Award, the B.C. Roy Award, and the most prestigious Padma Shri and Padma Bhushan Award by the Government of India, which are the highest civilian awards that are offered by the Government of India. And my next chairperson is Professor Dr. Sudeep Gupta. Again, he is one of the most eminent oncologists in the country, and one can say that he is an authority in breast cancer and in gynecological malignancies in the country. And he has already worked for 3 decades in the field of medical oncology, and he is currently the director of the ACTREC Tata Memorial Hospital, Mumbai. He is an outstanding researcher, and his special interest is in breast cancer and gynecological malignancies, and he has done pioneering work in both these malignancies. And his recent work on BRCA1 and 2 is well known to the Indian and international faculty. His areas of interest are cervical cancers, ovarian cancers, lymphomas, and multiple myelomas. He is recognized nationally and internationally, and is awarded extensively in his career. It's real honor and prestige to have both Professor Dr. Advani and Dr. Sudeep Gupta as chairpersons for this meeting. I request both the chairpersons to take over and introduce the speakers and take this meeting forward. Thank you.
Sir, Dr. Advani, sir, you are muted. You have to unmute yourself. Yes.
Yeah, thank you very much. I would request my colleague, Dr. Sudhir Gupta, to carry with the program.
Thank you very much, sir. And thank you, Dr. Raja, for your kind words about Dr. Advani, who of course needs no introduction, and myself. I just would like to make the point that I no longer treat hematological malignancies, and I treat only breast and gynecological cancers. But you know, this line has tagged along with me for many, many years from a long time ago when I used to treat those cancers. So without much further ado, let's begin with the program. And we are all looking forward to listen to Dr. Dattatreya, who's our very eminent medical oncology colleague. He's a consultant medical oncologist at Hyderabad. Many years ago, when he was a young consultant, young faculty member, I was speechless, left speechless by an outstanding talk that he gave at Delhi. And since then, I have tried to invite him to most of the conferences that I organize, most of the times unsuccessfully, but it is always a pleasure to listen to him. So Dr. Dattatreya, I am looking forward to listen to you, and then followed by Dr. Charles Keir, who all of us know from his numerous publications in the New England Journal of Medicine and many other prestigious journals and impact-making studies. But first, Dr. Dattatreya, please can you deliver your talk? Thank you.
Thank you so much, Sudeep sir, for those for such a kind introduction and all those good words about me. So I am here today to set the ball rolling and set the context for our guest speaker, for the guest of honor today, to the foreign speaker we listen to. So to set the bench for that, I thought I'll talk about the current perspective in HER2 positive early breast cancer with regard to the Indian data. And accordingly, I tried to look at various publications, and I have tried all 90% of them are publications of 2020 by Indian authors, or a few of them maybe 2019 or some 2021. So next slide. So this publication is by Mathur P. et al. In the JCO Global Oncology in 2020. And the bottom line they gave was that cancer statistics in India 2020, breast cancer has surpassed all other cancers. And in the same paper, Mathur et al. Also talk about, next slide, the fact that a late presentation is common. When I say late presentation, I'm talking about localized breast cancer patients who have a regional disease as well. So that's almost like say 57%. So most of the patients do come to us in locally advanced stage. Next slide. Now this is one more presentation data of more than 1,200 patients. We have younger patients, the median age being 47 years. Majority were symptomatic at presentation rather than being picked up by screening. It was patients who had symptoms. Median duration was around 4 to 5 months. Median lump size 5 centimeters. And most commonly, it was the IDC history. This was in the breast disease in 2020. Next slide. In the same paper, the authors also showed us that there's an increasing trend now towards breast conservation rather than mastectomy. And I think, of course, in the metropolitan cities or in various cities, it's definitely BCS. But gradually at other tier 2 cities and tier 3 towns, etc. also, we are seeing an increased trend towards breast conserving surgery being performed. The next slide. So this is again from the same authors, and they tell us that post NACT, because we do have a good number of patients who are locally advanced or who deserve neoadjuvant chemotherapy. So post NACT BCS is safe even in large tumors and LABC patients, though many require oncoplastic procedures for satisfactory cosmesis. So BCS benefits can be offered to a majority of patients with the help of neoadjuvant chemotherapy without compromising the chances of cure. Next slide. Now this is a paper by DC Doval et al. Where they talk about the proportion of patients who get radiation therapy after primer surgery. And I think at all centers, we all follow the guidelines what the recommendations are for adjuvant post-op RT, and this is a data of close to 3500 patients from 3 key centers. Next slide. Now here we are talking about the incidence of HER2 positive breast cancer being around 25% of all breast cancer patients. We all know that anti-HER2 treatment is the mainstay, whether it's early or advanced HER2 breast cancer. And over the last decade, the evolving trend across the entire world also has been tried to be copied in Indian scenario as well. And there are challenges in HER2 positive breast cancer treatment. A publication, next slide, in the IJC in 2021 March will makes a list of all those challenges. The important ones are residual invasive disease still continues to be an issue, and majority of the patients, despite having not achieved a path CR, continue to be treated with adjuvant trastuzumab only. Indian patients have limited access to HER2 target therapies because of financial constraints. The advent of biosimilars, especially the trastuzumab, changed the situation a lot, and with the availability of the generic Kadcyla now, that is potentially going to further improve. In fact, the US FDA till 2021 has approved around 8 HER2 targeted agents. Next slide. But as far as the Indian patients are concerned, we have access to trastuzumab, lapatinib, and now TDM1 or trastuzumab emtansine. Next slide. So this was a publication in the IJC in 2020 by Nair et al., where they looked at the impact of trastuzumab, saying that the impact was a marked improvement outcome. During the initial years of launch, it was an expensive treatment, which was beyond the reach of majority of patients in our Indian patients. And then the advent of various biosimilars, of various companies coming with biosimilars, the access improved and much more patients are able to take the benefit of this treatment compared to early on. And therefore, the key message was access to TMAB has been improving constantly. They in fact tried to compare from 2008 to 2016. Next slide. And then from 8.61% in 2008, it actually went up to as high as 57% in 2016. I believe now more than 80% of patients in 2021 or even 85% of them are able to afford or get adjuvant trastuzumab or in the metastatic setting as well. So increasing access to HER2 target therapy in patients of HER2 positive breast cancer because of biosimilars being available, and also in some places using, in some particular patients using shorter durations of adjuvant trastuzumab, and funding supports have played a key role in making sure our patients of HER2 positive breast cancer patients get the benefit of trastuzumab. Next slide. And this is access to trastuzumab by stage. In stage 1, 2, or 3, 65.76%. Now this is something like telling us that there are some caveats as well. For example, using short course adjuvant trastuzumab, and then there are some patients who, like almost 103 patients here, got only 12 weeks of trastuzumab. We know that we choose that only for patients who have low risk disease or are predisposed to cardiac toxic side effects, and I think that is fair because at the end of it, we don't want to harm our patients. With that, I now come to a 2018 publication in the SAJC, next slide, where they looked at practical concerns on HER2 positive early breast cancer patients. So tumor size between 0.5 and 1 centimeters, adjuvant TMAB treatment can be recommended based on other risk-benefit factors. So this was more like a poll which was performed by various expert oncologists in the country. Next slide. What protocol to use if the tumor size is 2 centimeters? More or less, they agreed weekly paclitaxel plus trastuzumab between 1 and 2 centimeters, or TCH if it is more than 2 centimeters. So majority of them recommended non-anthracycline based regimens. Next slide. Would you add another anti-HER2 agent to trastuzumab? I think cost of therapy and the benefit in increment being not that great, is what is not, that doesn't push us, or we are not enthusiastic about incorporating either pertuzumab or naratinib. But if cost were not an issue, then maybe the impression might be different. Next slide. So what about continuing TMAB and anthracene node positive patients? I think all comers who are node positive, use of anthracene is not for all comers. It's basically considered on a case-to-case basis, including patients who are high risk. And lastly, use of, next slide, dual HER2 blockade, for example, TMAP plus pertuzumab, but the cost of Perzeta is beyond reach for majority of the eligible patients. And in advanced breast cancer patients also, incorporating trastuzumab and lapatinib also is like to a less number of patients and mostly in advanced breast cancer. Finally, next slide, I look at some of the pivotal studies of neoadjuvant trastuzumab and pertuzumab, Neosphere and Trifina, both of them phase 2 trials. Next slide. And we know that PAT-CR rate is higher by using dual HER2 blockade with chemotherapy. In India, PAT-CR rate is expected to be lower as most patients are LABC and can afford only single HER2 blockade, which means that many patients will have residual invasive cancer after neoadjuvant chemotherapy plus targeted therapy and thereafter surgery. And we clearly understand, next slide, that HER2 positive breast cancer patients with residual disease with PAT-CR not achieved have poor outcomes. Achieving a PAT-CR hazard ratio of 0.31 with regard to better EFS than not achieving PAT-CR. Similarly, achieving PAT-CR improves the OS hazard ratio of 0.13 than in those patients who have residual disease despite getting the full neoadjuvant chemotherapy and target therapy. More often than not, this would be only trastuzumab and chemo, and very few patients go on to get, for instance, pertuzumab plus trastuzumab plus chemotherapy. So escalation of adjuvant target therapy is the need of the day for reducing the recurrence. Next slide. So let's look at slightly, very quickly at the definition of high risk HER2 positive early breast cancer, which means these patients have a risk of a 10% or more than 10% risk of recurrence. Residual disease after appropriate neoadjuvant chemotherapy and anti-HER2 treatment, or if surgery has been done first, then node positive disease or T3 or T4 disease. Next slide talks about drugs like naratinib, drugs like trastuzumab plus pertuzumab or TDM1, which got FDA approvals respectively in these years in 2017 and 2019. Now, what about the access to these three therapies in India? My perception, next slide. Naratinib, pertuzumab, TDM1, most of the high-risk patients end up getting only trastuzumab as the access to the above therapies is a big challenge. So all these conclusions in the last 10 minutes has been based on publications by Indian authors or group of authors in 2020. Almost all the papers I showed you were 2020 or 2021 publications. So let's take it ahead with further learnings. Next slide. How to optimize the treatment of HER2 positive EBC cancer patients in India now that we have TDM1 also available, the available anti-HER targeting molecules, and best using those resources. We have with us today the experts from India, and especially Professor Dr. Charles E. Geer, involved in many early breast cancer trials, and they'll enlighten us about how we can optimize these outcomes. And in 2030, our publications may show much better outcomes than what I have showed you today. Thank you so much, everybody. Thank you, Sudeep sir and Advani sir. Over to you, sir.
Thank you, Dr. Dattatreya. Dr. Advani, would you like to introduce Dr. Charles Geer? I'm not. Okay, so I suppose it is my privilege to introduce Dr. Geer. So Dr. Charles Gayer is the Deputy Director of the Houston Methodist Cancer Center and has spent a large portion of his academic career on the conduct of multi-institutional phase 3 clinical trials with a focus on the development of HER2-targeted therapies. He has had several leadership positions, including in the NSABP. And we all know how impactful and how important the NSABP trials have been in the practice of breast cancer. He currently serves as the Vice Chair of the NRG Breast Committee and the Chair of the NSABP Foundation Breast Cancer Committee. He was the study PI of the Catherine trial and the co-chair of the Olympia trial, which has made quite an impact in recent times. He has a large number of highly impactful publications to his credit. And I was just looking up the landmark publication on the use of lapatinib and capecitabine in HER2-positive metastatic breast cancer. And I just saw that it has, as of the most recent reckoning, notched up close to 3,700 citations. I don't know what the others think. In my personal opinion, capecitabine and lapatinib continues to be a very important and a highly effective treatment for patients with metastatic breast cancer. We all look forward to listening to Dr. Gayer. Dr. Gayer, we are grateful that you spared your time for us this evening and your morning, and we are looking forward to listen to you. Thank you, and over to you.
All right. Thank you, Dr. Gupta. I appreciate the invitation to participate in tonight's meeting. I think and I really enjoyed that previous presentation. I think I would love to have had that before. I might have prepared my talk a little bit differently, but that was very, very informative. I will try to, let's see, it won't let me share. I'll have to stop sharing so I can go to my slides. Is that all right? Thank you. Apologies for that. It's always hard to get that, to know which one is showing. So, yeah, I was asked to share some, I guess, perspectives and thoughts about really how we are moving to an era where we really can start thinking about optimizing our therapy of patients who have HER2-positive early breast cancer with a little more selectivity to try to get the right amount of therapy, the right agents, to give each patient the best chance for cure with as little therapy as possible. Obviously, there's a lot of cost issues, toxicity issues, and so I think I'm going to kind of focus on that idea of optimization. I won't spend a lot of time on this with the previous discussions, but I do think, as we heard from the previous speaker, that the development of trastuzumab as the core therapy for HER2-positive breast cancer really has been transformative, and it's fantastic to see that the biosimilar has really opened up the therapy, this highly effective therapy to women with breast cancer in India. I mean, that data, we saw a number of phase 3 studies that were evaluating chemotherapy with or without trastuzumab report around 2005, and they were really transformative. But beyond that, we really haven't had a lot of movement in terms of further refinements until the past few years. Now, the first study that really showed some advance was the Affinity trial, which really was following up on the very impressive results of Cleopatra, which did appear to show that dual antibodies with docetaxel were remarkably more effective for treating women with metastatic disease in the first-line setting. I mean, there was this remarkable improvement in overall survival and metastatic disease, which really, I think, points out that this trastuzumab is important in targeting and shutting down that oncogenic activated HER2 pathway cascade. But it clearly also, and I think Cleopatra really suggested it, does tell us that the antibodies are also important in engaging the immune system, is how I view this. And so I do think that the dual antibodies do have some advantages in metastatic disease. So I view that kind of as when possible. I think that still is standard of care, preferred therapy for metastatic. But there was obviously the question of, is it going to really make an impact in early breast cancer? And the Affinity study was a very ambitious global trial, large accrual. You can see 4,800 patients, very clean, straightforward design that randomized patients to get chemotherapy, and doctors were allowed to use anthracycline, non-anthracycline, whatever they considered optimal for their patients. And the randomization was between trastuzumab alone and the trastuzumab with pertuzumab using a placebo-controlled design. And this study was activated around 2011, 2012, a lot of interest in the results. But at ASCO in 2017, when Dr. von Niekwitz presented the data, it was a positive study statistically, in that because it was such a large study, and there was some difference in the events between the two arms, it just met statistical significance. But obviously, the immediate question everybody had is, well, okay, statistically significant may not mean clinically significant, particularly given the cost of the addition of pertuzumab. So this was really kind of a somewhat disappointing result, even though it was considered a positive trial. We all wanted to see further follow-up. We knew that initial data was at 3 years. HER2-positive breast cancer recurrences evolve over 5 years in ER negatives, over 8 years in ER positive. So we all wanted to see follow-up, and Dr. Picart did present that data at San Antonio 2019, and it has now been published. And initially it looked like at the 3-year mark, what Dr. von Niekwitz reported, it seemed the benefit might be segregating to the hormone receptor negative group. There wasn't much difference in the hormone receptor positive group that was evident. But with the additional follow-up, as you might expect, the ER positive cohort began to have more events. And so what you see by 6 years is that really the benefit seems very, very similar in both the ER positive and the ER negative. So hormone receptor status in HER2 positive patients wasn't differentiating. But what clearly held up was that nodal status, degree of risk was. You see in the node negative low risk cohort, these patients do remarkably well with trastuzumab. Clearly, there is no role for pertuzumab in that patient population. In the node positive higher risk group, we do see that with trastuzumab, by 6 years, we're approaching a 20% recurrence rate. The recurrences, this was a composite disease-free survival, invasive disease-free survival endpoint. But in HER2-positive breast cancer, most of these events are recurrences, and this was improved to a degree with pertuzumab. So, the study is positive, but I think it really clearly shows that we cannot go further than this in the adjuvant setting, because now with a lot of chemotherapy, a lot of antibodies, we've gotten folks up to, an 88% chance of invasive disease-free survival at 6 years. You can't justify layering on more therapy. You really need to start thinking about, well, could we have another way of identifying the patients where even this therapy isn't enough, where we might need to do more? And then certainly, this group, you don't want to be giving them more therapy when they're already doing quite well just with trastuzumab alone. So the path out of this dilemma that we found ourselves in at the end of Affinity basically was there in the neoadjuvant patient population. And in 2011, the FDA approached the global groups that had been active in doing neoadjuvant studies that were looking at interventions to improve PCR rates and who had long-term follow-up, to look to see could increasing your PCR rate be a surrogate for improved long-term outcomes. And so the FDA worked with all the groups shown on the slide to conduct a meta-analysis, a patient-level meta-analysis that Dr. Cortazar presented at San Antonio in 2012. And not surprisingly, in this very, very large study over 11,000 patients, we see these curves that we're all very, very familiar with when it comes to neoadjuvant therapy. Patients who have a PCR do substantially better than those who do not have a PCR. And we saw slides from Indian patients earlier that show this same well-established pattern. Now, in terms of, this, of course, these were earlier studies. Some of these studies were done before we were even aware of HER2 positive status. They were that old. So, but there were some that were done in HER2 positive patient populations where we had the HER2 status identified. You can see the numbers go down here. So there's some wide confidence intervals around these graphs, but I think they are interesting to look at, because we had enough patients that we could look at how patients did both with PCR and in the absence of PCR in the no trastuzumab era. And then we could compare with how they were doing with trastuzumab. And we were able to do that both in hormone receptor positive and hormone receptor negative. And I think the interesting thing is you do see that the addition of trastuzumab in the hormone receptor positive patients really improved both groups, both the PCR patients and the non-PCR patients in hormone receptor positive breast cancer seem to do better with trastuzumab. So it helps all of those patients clearly, and this is really not a surprise. We also see, again, the PCR patients seemingly do better when they got there with the addition of trastuzumab. But again, I tend to think, okay, is this immune effect, this sustained effect coming in as hypothesis? Not a big impact, though, on the patients who do not have a PCR. And we saw in the previous presentation the important data, neoadjuvant data, that really got the pertuzumab development effort going were these two studies. The Neosphere study, that was a very straightforward study that just looked at neoadjuvant therapy consisting basically of 12 weeks of treatment. And the main randomization that impacted was these two arms, docetaxel trastuzumab versus those two with pertuzumab. And Dr. Diani demonstrated a very nice increase in PCR rate just with the addition of pertuzumab from 29% up to 46%. Was also this intriguing data that there is this subset of patients who just with antibodies have a PCR rate, which remains interesting. And I think we're now getting to where, and I'll talk about this later, where we're now actually seeing trials done, really trying to maybe better identify this subset of patients. Now, you know, these PCR rates are it's impressive about the increase, but we don't tend to limit our neoadjuvant therapy just to 12 weeks of treatment. And shortly after, the German groups looked at adding pertuzumab to the standard anthracycline taxane regimens and giving it concurrently with the anthracycline or sequentially following the anthracycline. They also looked at adding pertuzumab to the TCH regimen and showed this remarkably high PCR rate that you are able to achieve around 60% with the addition of pertuzumab. So dual antibodies, multi-agent chemotherapy, we really are getting the majority of our patients to a PCR status. And so going back to that previous slide, you know, when you think about, you know, where we are now with our regimens in our HER2 positive, hormone receptor positive patients, about 50% of these patients will get to a PCR, and in the hormone receptor negative patients, it's even better. But as I said, we've kind of maximized our ability to push in the neoadjuvant regimen to get to these points. And even with these aggressive regimens, we still have the problem of what about the non-PCR patients who don't do well? And so the neoadjuvant setting, in a sense, provides the opportunity to find out which patients have HER2 positive breast cancers that will respond very well to our standard regimens, identify those who will not, who then are at high risk, who might benefit from an escalation strategy. And that's basically what the Catherine trial was developed to address that specific problem. Now, we had been talking in NSABP that, you know, it's been obvious to a lot of people that these non-PCR patients are higher risk across all tumor types, so they would be a logical group to look at salvage therapy of some kind, but you want to pick a drug that has demonstrated activity in a similar patient population. And, you know, the major justification for selection of TDM1, I think, really came from the Amelia study, which was a metastatic disease trial, a huge metastatic disease trial, almost 1,000 patients. Important eligibility criteria were patients who had progressive metastatic cancer that had been exposed to prior taxane trastuzumab. So similar to our patients with residual disease who did not PCR with taxane and trastuzumab. And it was a randomization of capecitabine lapatinib, which was the standard therapy for this patient population at that time, randomized with TDM1. And I'm not going to spend a lot of time on it. I think this is the best statement about how effective this therapy was. You know, you see improved overall survival in a metastatic disease trial. Anytime you see that, you know, an improvement in survival in a metastatic trial, you know you have a very, very effective therapy. And of course, TDM1 has a much better toxicity profile than capecitabine and lapatinib. So in the second line setting where this study has been done, TDM1 has largely displaced lapatinib and capecitabine, certainly in the US and in many other countries where it's available. So let's get into Catherine now that we kind of set the stage for it. When we designed Catherine, we wanted to, you know, have a broad eligibility criteria. We basically were interested in identifying patients who had received standard trastuzumab-based chemotherapy. We wanted, and who had finished all planned chemotherapy. So we wrote our eligibility criteria that we wanted a minimum of 6 cycles of chemotherapy. This allowed inclusion of the TCH regimen. If we'd allow anthracyclines, we really didn't specify that. We wanted to make sure they had at least 9 weeks of trastuzumab. As this study was being launched, pertuzumab was being approved in the US. So we knew that if US doctors were going to participate, we had to allow a second HER2 targeted agent. So we do have patients in the trial who had received pertuzumab, but they are a small subset of the overall. So that was kind of the idea. We want to get patients who have had standard neoadjuvant regimens with trastuzumab at least as a minimum. And they basically could have any stage of disease at presentation. We included patients who had presented with locally advanced disease, T4, N3. All those patients could come into the trial. So this was an unusually broad eligibility criteria. The only ones we excluded were these mammographically detected very, very early breast cancers. So we had pretty broad rules about the disease the patients had to present with. The requirement to enter Catherine was that they had to have residual cancer in the breast or the axillary nodes. Because we knew we had a very heterogeneous population of patients, we decided to have a number of stratification factors, basically sort of inoperable patients who presented with inoperable disease, locally advanced disease, versus those who were operable but chose to, but the doctors chose to use neoadjuvant therapy. Hormone receptor positive, of course, is straightforward. Clearly, we wanted to make sure we didn't have imbalances between patients who had had single agent trastuzumab versus dual HER2 targeted. And we do know that patients who have positive nodes after neoadjuvant therapy are at particularly high risk. So we wanted to make sure that pathologic nodal status was balanced in terms of no node positive versus node negative, or nodes were not done. When we set up the study, with the TECHNO trial from German groups had looked at outcomes in patients who did not have PCR following a sequential anthracycline taxane regimen with trastuzumab, and they had a 3-year IDFS of 70% on that trial. So we thought, a hazard ratio of 0.75 would have given absolute improvement of about 6.5%, and that would be clinically meaningful. So the study was really set up under those assumptions to try and identify, again, a hazard ratio of about 0.75. As you always do in these large studies, you do set up early interim analysis in case the therapy is more robust than your statistical plan had assumed. We did our interim analysis at Catherine when we were 2/3 of the way through the events. We specified that if we crossed that interim boundary for invasive disease-free survival, we would then, of course, do an interim overall analysis, not expecting it to be positive at that point. But clearly, if you cross an early boundary for IDFS, there are regulatory implications, and there will be a need to see, is there anything going on in survival that might impact on regulatory approval? So this is why that was included. So what was the patient population that came into Catherine? I think this is real important for clinicians who are considering using TDM1 to understand the patient population that was in Catherine. We had relatively young patient population. About 20% were less than 40. Under 10% were above the age of 65. This was done as a global study, but a lot of the patients came from the German breast group and from NSABP. So a majority of the patients were white, but we did have, representation across the ethnic groups. You can see the bulk of the accrual actually did come from Western Europe. Most of the doctors at the time these patients were accrued were still using anthracycline-based regimens, as you can see here, so about 75%. A quarter of our patients had presented with inoperable disease. Not surprisingly, we do know that when you use neoadjuvant therapy, we've seen it in the, it was shown in one of my previous speaker slides, that the PCR rates are higher when you have ER negative disease and when you have ER positive disease. So it wasn't surprising that the majority of our patients coming into Catherine were ER positive, a little over 70%. As I mentioned, 80% of the patients just received trastuzumab. We allowed other HER2 targeted agents, but the vast majority of those were pertuzumab, as you can see here. And about 46% of our patients were node positive, but our stratification force worked, which you expect going in that's going to be the case. What about the amount of disease after neoadjuvant therapy? Well, we, again, important to have balance there, because we do know that the greater the residual cancer burden in terms of volume, nodal involvement, the higher risk for disease. So you do want to have balance. And we did have balance, but we did see that we know trastuzumab and chemotherapy are quite effective. So 44% of our patients really had a centimeter or less of residual disease, even though we had that pretty advanced presentations. About a quarter were 1 to 2 centimeters, then we had a quarter 2 to 5, and we did have some patients that really had just not responded very well at all to neoadjuvant therapy. About 45% of our patients were node negative, and when you combine the small tumors with the node negatives, to have a very low risk group, that comprised a little over 20%. So we do have information on even those patients who have a relatively small amount of residual disease. And these are the remarkable results that we see really how effective TDM1 is for this patient population who do not have a complete pathologic response with neoadjuvant trastuzumab-based therapy. We had predicted we would see a 3-year invasive disease-free survival of 70% with trastuzumab, and we actually had a higher number there, 77%. So sometimes this can be challenging if your control group does better than what your projections are. And oftentimes that's used as perhaps this is why we didn't see benefit from the therapy. But here in Catherine, that did not inhibit at all our ability to see an improvement. We were hoping to see an absolute 6.5%. We saw an absolute 11% improvement with a hazard ratio of 0.5. So this was clearly a case where the activity really exceeded what we were hoping that it might show us. So very, very strong results, clearly exceeding the early reporting boundaries that had been established. The other thing I think about the curve that's important to look at is how quickly they start separating, and that, over time, the curves just seem to keep widening. So it will be very interesting, to see what, with additional follow-up, how these Kaplan-Meier curves confirm. But it is going to take a while. I will share that the event rate in both patient groups is coming a bit slower than what we had planned, which is always good for patients. But I think, again, it points to the activity of the therapy. So we had a real heterogeneous population. We had this very large effect overall. But again, what you always want to go in and look to see, is there a heterogeneity of effect, or does it look like it's pretty consistent across groups? And I think an equally remarkable thing about Catherine was how remarkably homogeneous the benefit was across virtually all the groups that we were able to look at. You see, the hazard ratio was virtually, it's right around 0.5, irrespective of whether you presented with inoperable or operable disease, ER positive, ER negative, whether you got trastuzumab alone or dual antibodies, whether you were node positive or node negative. So it's a very consistent effect. All age groups benefited. There did not appear to be any evidence that there was an ethnic group that wasn't deriving substantial benefit. So in terms of relative activity, TDM1 is broadly beneficial. Now, I do think, a question that comes up, again, in resource-constrained countries that I get a lot is, well, is there enough of a risk to warrant therapy in an individual patient? And I think these plots are very helpful because clinicians can come and see, well, what would my patient do if I just continued the trastuzumab? You can see that if you had a patient who presented with inoperable disease, she's got a very high risk of recurrence. If they were in, hormone receptor negative, higher risk of recurrence. So you can kind of use these tables to maybe make decisions, because it's for individual patients, it's always about what's the absolute gain for this patient. You know, the relative informs, but the relative can only inform when you understand what your baseline risk is, your residual risk that you're trying to improve. So I do encourage people to look at these when they're talking with individual patients. When you look at the volume of disease that's left behind, we see a little more heterogeneity, but clearly there is no evidence that there are groups that don't benefit. It does look like the hazard ratio is a bit higher for this small group, 0.66. That exceeds what we said we thought 0.75 would be clinically meaningful. So, you know, that maybe this group doesn't get quite as much benefit, but when you combine it with, and go back and look at the nodes, combine that small residual tumor with negative nodes, you know, you see a hazard ratio of 0.6. And again, this is why I think it's useful to see what the trastuzumab looks like. You know, an 85% 3-year invasive disease-free survival is pretty good. You know, does that patient need to have the toxicity and expense of TDM1? Well, if they do, they can go up to 90%. So it gives you that absolute number that you can really use, I think, in your clinic to have discussions with patients. One area that it does look like that could have an impact, I think, and this was alluded to in one of the earlier slides, we know that HER2 positive breast cancer really is a heterogeneous group. You get benefit across the group with trastuzumab, but as we start looking at optimization and maybe where there's places to opportunity for further improvement, I do think it is important to see that those patients who are IHC 2+, perhaps a lower level of expression, maybe a little more heterogeneity, might not have derived as much benefit as the really clear HER2-driven cancers. So that's possibly one subset. I would not withhold the therapy, but when you talk about opportunities for optimization, maybe considering future trials, that's a group. Now, one question that I get a lot, and there seems to be a lot of concern, again, it relates to that idea, well, what if you have a patient where they almost got there? You know, we RCB1s, the system that Fraser Simmons developed, those patients really do just about as well, and pretty much as well as patients who have a PCR. But Fraser developed that model and did that really initially across subtypes of breast cancer, and with additional number of patients, he has updated things, and you can see here that the RCB1 patients really track more with the RCB2 patients in HER2 positive breast cancer than they do in PCR. So in HER2 positive, the PCR is important, and if you've got residual disease after neoadjuvant therapy, there is some risk for recurrence. And so it is a patient population that I think one has to at least consider the possibility of using TDM1, even if you do have just a small amount of residual disease. Another question that we've gotten on Catherine is, well, what if I test my residual disease and it's HER2 negative? If that's the case, why would I want to give that person a HER2-directed therapy like TDM1? And so, you know, on Catherine, we ask our investigators they had to submit a baseline core biopsy to determine HER2 positive status. If that wasn't available, they could submit the post-surgical specimen. Most of the patients came in based on central assessment of their core biopsy. And we asked for both. So we had paired specimens in 845 patients who were centrally confirmed to be HER2 positive. And so we did central testing on the residual disease, so we could have the paired analysis, and we did find, as we know, that there were in our study 8% of the patients who had pair samples who were HER2 positive on their core were negative on the residual disease. So this is a small subset. You know, there's all kinds of uncertainty there, but we did think it was appropriate to look to see, was there any suggestion that these patients might not benefit from TDM1 as was seen across the study? And this is the data. You can decide what this means. It's clearly we can't make any statistical claims here, but there were 42 patients who wound up testing negative on their tumor, who had been randomized to TDM1, and we had already seen 11 events in those 42 patients, IDFS rate of about 74%. So, with those patients are at risk. The interesting thing was in the 28 patients who had been randomized to TDM1, we had yet to see an event. So, while you can't make a statement saying this proves TDM1 is effective, I think you can say that, well, since in the context of the overall trial, this data does not suggest that you should withhold TDM1 in these patients, because there's no evidence that they might be behaving differently than the overall treatment population. We have been trying to get this published. We presented it at a meeting, but it's been very, very challenging because it is retrospective, and you get lots of people worrying about the statistical importance of it. But this is as good a data as we'll probably ever have. So I think physicians need to be aware of it. We have also tried to look to see, are there any biomarkers that we might test on the residual disease that could maybe identify patients where it doesn't seem to work, or where it's particularly important. And of course, PIK3CA has been a recognized confounder of HER2-positive breast cancer and metastatic disease. Tumors that are PIK3CA mutated and HER2-positive have a worse prognosis than those who do not. Early cancer, it's been a little bit unclear. We decided we should look at it in our patients in Catherine, those who have residual disease, and you basically see PIK3CA doesn't tell you anything about this patient population. Those who are mutated, those who are not mutated, had virtually the same hazard ratio. And there was just when you looked at the cohort outcomes across the whole, everybody merged together, no difference. So there doesn't even seem to be any prognostic information. So PIK3CA assessment just has no clinical utility in this patient population at the present time. We also did gene expression testing, and we dichotomized the groups into the upper half, lower half of HER2 expression to see if HER2 expression intensity might have an impact. And it's a little. Hopefully you can follow this. The low patients here, low expression patients, are in the lighter colors. So this light color that I'm showing here is how patients with low HER2 expression did with getting trastuzumab. They certainly did better than those with high expression with trastuzumab. But if you gave them TDM1, they did better. The patients with high expression who got TDM1 did markedly better. So HER2 expression doesn't seem to identify a group that, in a sense, I guess I should say it, low HER2 expression does not say there is no benefit, but clearly the magnitude of the benefit is, in an absolute sense, is going to be less. Where you clearly need it unquestionably is in these patients who have that high HER2 expression. Those are the patients that really clearly do benefit. And we went ahead and looked at some signatures, immune signatures, different signatures. Again, no difference. So we really just have not been able to identify any subset of patients who are not likely to have their residual risk reduced by 40, 50% with TDM1 when they have residual disease for IDFS. Another impressive part of the database, I think, is, of course, we know HER2 positive breast cancers are an aggressive cancer. Most of your events, when you talk about invasive disease-free survival, you are including local regional recurrence, contralateral breast cancers, death, NED, but the majority of your events are distant recurrences. And when you get local regional recurrences, distant recurrences usually are not far behind. You can see that this therapy impacts on distant recurrence rates, highly significant, 0.6. So it's very effective in really attacking the problem, the thing that takes the life of our patients. This breaks out the IDFS events, just basically reinforcing what I just said. The bulk of the events are distant recurrence. You do see that distant recurrences are reduced, local regional recurrences are reduced, even contralateral breast cancer is reduced a bit. Very encouraging is that we did not see a difference in death NED. This would be if there was increase with TDM1 there, you would worry about toxicity. We did not see that. The one place where TDM1 was disappointing, there had been some evidence in metastatic trials that patients with brain metastases sometimes respond to TDM1. So there was hope that we might see something there. The interesting thing is that there seemed to be a higher number of patients, slightly higher number of patients who presented with CNS metastases as part of their first event than what we got in the control arm. So we did want to look at that important question because we had seen a similar thing in the early adjuvant trastuzumab trials. And what you have happen, is this competing risk phenomena. Basically, patients who have occult metastatic disease that includes brain metastases, if you give them a more effective systemic therapy that doesn't impact on the CNS disease, you're going to block that systemic disease, but the CNS disease will still become apparent. So if that's going on, you would predict you might have more CNS disease as a first event, which is what we had. If it is that, with subsequent follow-up, you should see the other arm, the control arm, in a sense, catch up because the patients had equal, you have to assume equal distribution of patients with brain metastases across the two. And here you've suppressed the systemic disease more effectively than you do here. And that is indeed what we've seen on Catherine, that there has been a catching up, of the patients on the trastuzumab arm, very, very consistent with this idea of competing risk. We also see that the median time to CNS recurrence, is longer here in the TDM1 arm. So we do not believe that this in any way reflects an adverse CNS effect of TDM1. It's just TDM1 is not helping us with that problem, and there's still a bit of an unmet need. We also looked at survival after CNS recurrence. No difference whatsoever. So real quickly, what about tolerability? This is always an issue. These are patients who have been through a lot of therapy, surgery, radiation therapy. So how did they do with TDM1? I think it's important to keep in mind that our control arm is trastuzumab, which is a very well-tolerated therapy. We do see that, and on the trial, patients were to get 14 more cycles of either trastuzumab or TDM1. We see that 20% of patients did not finish the full TDM1, but that was higher, 10% higher. Did not receive the trastuzumab with TDM1. It was 10% higher. So clearly there is more toxicity. We did have dose reductions built in, and some patients require dose reductions, but this is actually a relatively small number of patients requiring dose reduction. So TDM1, has more side effects than trastuzumab. We had a little bit higher discontinuation rate, but I think the real difference is 10%. It's not, you can say, oh wow, a third of patients weren't able to finish the year of therapy, but you've got to compare that to the fact that 20% won't finish trastuzumab. In terms of the adverse events, again, both groups are actually pretty low. Grade 3 AEs in 26% of patients getting TDM1 versus 15% in trastuzumab. The big difference really was that we did have a higher number of patients discontinuing TDM1 because of adverse events. You can see 18% versus 2%. Fortunately, not really any difference there in AEs with fatal incomes. This was the one patient was kind of complicated. She had thrombocytopenia. She fell, and after the fall with the thrombocytopenia, she developed intracranial hemorrhage. So did she bleed and fall, or did she fall and bleed? We just don't know. When you look at the specific reasons why these discontinuations happen, most of these were due to asymptomatic laboratory findings. When we launched TDM, the Catherine study, there was still concerns about toxicity, hepatotoxicity in particular. So we had pretty conservative discontinuation criteria that were worked out with the regulatory agencies. So you can see about half of these were due to asymptomatic laboratory abnormalities that led to the discontinuation. No difference in cardiotoxicity. The other half were just spread over all kinds of things. So there really wasn't a clear pattern other than the laboratory findings. We prepared this slide to try and give a sense of really that, when you're talking about adjuvant therapies and curative populations, you particularly want to know how are we doing with our grade 3s. Those are the things that are clearly the most important. So we developed this using the darker colors to show the grade 3s, and you can see how rare grade 3 toxicity is with trastuzumab. And we did see some capping, dark blue capping in some of our categories, but again, they were largely laboratory based, platelet count, ALT, AST. The one that is clinically important, even in lesser grades, grade 2, grade 1, neuropathy is clinically important at any grade. So this is something that you do have to watch. TDM1 is the chemotherapy is a mitotic spindle inhibitor, so it does have neurotoxicity. These patients have prior taxanes, so this is an issue that one has to be monitored, and is a reason to discontinue early if that develops. The survival data was immature, but we did see already that there were certainly numerically fewer deaths in TDM1 than we have with trastuzumab, which is a reassuring thing. We certainly cannot make any survival claims at this time, but the curves are certainly headed in the right direction. So, on the strength of the data, the TDM1 was quickly adopted by the various guidelines, NCCN, ESMO, St. Gallen, AGO, ASCO. There's really broad consensus that given the relative safety, the marked activity, that TDM1 is recommended for patients with residual disease. And this really has now kind of become the new treatment paradigm for patients who present with larger disease, T2 up to T4 in 0. Any node positive patients now should receive neoadjuvant chemotherapy, certainly, absolutely, with trastuzumab. We'll go plus minus on the pertuzumab without question. The chemotherapy has continued to kind of be this, and there was never really a good head-to-head comparison of did you really need the anthracycline or could you do less? People sort of were in camps. People adopted the TCH or TCHP regimen championed by Dr. Schleiman, or they were in the anthracycline camp for the most part. But I do think really Catherine and the study I'm going to show you next really ought to pretty much eliminate anthracyclines as a component of neoadjuvant therapy now, because we have good evidence that you can have very similar PCR rates without the anthracyclines, and even if there is a slight difference, we have effective therapy with TDM1. The study I'm alluding to that I think really has changed my thinking on this, I had kind of kept the leg in the anthracycline camp until I saw the results of this study presented at ASCO 2020. This was a straightforward trial looking at patients with stage 2 to 3 HER2 positive breast cancer. It was not a huge trial, but the PCR was the primary endpoint, but a good study. And it was basically giving patients both antibodies, dual antibodies, all taxane carbo versus sequential anthracycline to taxane carbo. And they had the Dutch group had previously reported these virtually identical PCR rates, which I thought, that's pretty impressive there, and really no difference there whatsoever. So, that I think was important information. But of course, there's always that, well, what about the follow-up? And that's what we saw at ASCO 2020. I mean, basically, these patients do very well with or without an anthracycline, is how I think you can say it. And so for me, this data really, I think, should move us all away from using anthracyclines in HER2 positive patients. The only time I still go to it is if I have a patient with more advanced disease that doesn't seem to be responding to the initial antibodies and carbotaxane that I use. Sometimes I will go to the AC in that clearly resistant patient population, but we don't see those very often. The other, they also showed, in terms of looking at EFS, again, for people who think, well, maybe my higher risk patients, maybe my higher grade patients. No, the forest plot really says it just didn't make a difference regardless of hormone receptor status, age, disease, any of the things. So I think it's just all reinforcing. And most importantly, as we expect, we know anthracyclines are associated with late leukemias, and so you do see those. So I think these are all very compelling reasons for us all to let go of anthracyclines. So then there's their survival curve. Real quickly, just to wrap up, I think, as we're seeing this high level of effectiveness now, I think we are getting to across the board, we are at a point where we need to start thinking about, well, what about the heterogeneity? Are there some things that we should start maybe looking at and considering, particularly when we're talking about possible de-escalation? And this is a work that Alex Pratt published that basically, this has been shown multiple times, is that the hormone receptor negative patients are pretty much largely HER2 enriched. You get much more heterogeneity when you have HER2 positivity. If you flip it around and then look at the expression level of HER2, again, when the HER2 is high, it's usually HER2 enriched. When it's low, you get more of that heterogeneity. So, and this has been shown in multiple circumstances. And at ASCO this year, the ADAPT group from Germany reported a very interesting. This is a very complex study with lots of arms. But for their patients who had HER2 positive hormone receptor disease, they did a randomization with a 5-to-2 randomization where the patients just received the antibodies as the sort of the investigational group, or the antibodies just with Taxol. And they, basically showed, the results. The results were that, they kind of showed, again, what Lupigiani showed in Neosphere, that you do sometimes get PCR just with the dual antibodies. But clearly, when you add even just paclitaxel, marked increase in PCR rates. I mean, these are almost hard to believe PCR rates. 90% PCR rate is just really remarkable. But it's interesting though when you kind of look at the data. Then they also then of course show that the 5-year IDFS by arm, the patients that got the chemotherapy did better than those who just got the initial antibodies. And the thing is the trial was designed so that people who got the initial antibodies did go on after surgery and get adjuvant therapy. So it wasn't that these patients didn't receive adjuvant therapy, it was just kind of delayed, done sequentially. And there's big confidence intervals, small numbers here, but I think that's kind of an interesting observation. And then when again you look at the group we just said, the Arm B patients who got the chemo, fantastic 5-year invasive disease-free survival overall. When you split out that other group, you do see that PCR patients do well, but again, you seem to have lost something by delaying the chemotherapy a little bit in that non-PCR group. because they did go on and get it. So I think this is a bit of a cautionary tale that we need to, de-escalation is a very interesting thing, but we might need to move a little cautiously. And the Breast International group, I think, is kind of moving cautiously. They're doing a decrescendo study, very interesting trial. They're focusing on the ERPR negative group. So a group where there's a high number of those HER2 enriched patients, lower risk node negative patients, and they're basically giving a taxane with the 2 antibodies, going to surgery, and if they have PCR, then they're just going to continue them with the antibodies. And that's their primary endpoint, to confirm that those patients do well. With residual disease, they're then doing some additional randomizations. The US groups are being more aggressive. This is the Compass HER2 study that's being led by ECOG Akron, where they're taking more advanced disease, stage 2, 3A, can be node positive, and they are treating them, this group, excuse me, just with the THP. Basically looking at the same thing and then seeing, can you just give these patients completion of antibodies without more chemotherapy? Again, part of their comfort in doing this is the reality that you can give these patients TDM1 and hopefully salvage them. The patient in the German study did not get TDM1, so there is this backstop that is part of the trial. But so I think this is the sort of thing that we're doing moving forward, looking at de-escalation. I think that the fact that your non-PCR patients have that potential of getting TDM1 has really strengthened things. I think I guess my question here, I was going to talk a little bit more about future trials, but I didn't want to go on too long. I know we have some discussion. So should I wrap it up there, or do you want me to run through a few more slides? Please, I will not be heard if you say, no, shut it down, you've said enough. Hello?
We may continue, please.
Should I keep going? Or should we end?
Please continue.
Okay, thank you. Just want to confirm. So in terms of, that's kind of focusing on the de-escalation side for those, can we use the PCR and de-escalate? There still are some unmet needs. The Catherine results were positive, but there's still some unmet needs. And, we do have this group of patients who have distant recurrence. And one of the studies that we are doing that's looking at that group is to add tucatinib to TDM1 to see if we can further improve the results that we saw with TDM1, basically trying to eliminate those brain metastases, particularly, and perhaps reduce the recurrences that we see happen more often in the patients who had presented with more advanced disease or who had more residual disease after their neoadjuvant therapy. And so this is kind of a one important escalation study that's being done that focuses on the brain metastases. And of course, this is predicated on the remarkable data from the HER2 CLIMB study that was reported at San Antonio 2019. This was a very impressive trial because it looked at patients with HER2 positive metastatic breast cancer who had been pretreated with trastuzumab, pertuzumab, TDM1. It allowed patients in with brain metastases, and they could include included patients who had previously treated stable brain metastases, which is kind of normal, but they also allowed in patients with untreated metastases who did not require immediate radiation therapy, or patients who had had prior lesions radiated and progressive. So they let in more patients with brain metastases. And we all know that as our patients with metastatic HER2 positive breast cancer progress through lines of therapy, brain metastases are a bigger problem. And the remarkable thing about the study was that it showed this improvement in overall survival in the trial. Again, anytime you show improvement in survival in heavily pretreated metastatic disease, you have a very effective therapy. And it even showed the same benefits for patients with brain metastases. So we are very excited about that study that looks at adding a small molecule tucatinib to TDM1, as a possible way to further improve therapy. Now, the other thing about Catherine is it clearly establishes how effective antibody drug conjugates can be for patients who have residual disease following targeted therapy, chemotherapy. These ADCs clearly can offer potential for salvaging patients. And the other follow-up study to Catherine, of course, is to look at an alternative ADC that has shown activity in patients who are refractory to TDM1 and go head-to-head and see, how it might do, particularly in the higher risk patient cohorts. And of course, trastuzumab deruxtecan is a very, very exciting molecule right now because of this remarkable activity. I mean, this is still one of the most impressive waterfall plots I have ever seen. This is a patient population that had pertuzumab, trastuzumab, TDM1, very late line therapy, and they had a remarkable 61% response rate in that heavily pretreated cohort, large cohort, 168 patients, and a progression-free survival at 16 months, and the overall survival still wasn't even reached out, moving out at 1.5 years. So really remarkable activity of the drug. The concerning thing about it is then the thing that we're all watching, of course, was the interstitial lung disease. We saw this, cumulative probability for developing ILD in that study got up to 20%. And there were 5 patients who died from their ILD. So this remains an issue that's going to have to be managed. But of course, this has moved forward now into a formal adjuvant study that's called DESTINY-Breast05 that basically takes the Catherine design, and the only modification is that because there is the risk of the ILD, this study is going to focus on those patients who, even with TDM1, still have sufficient residual risk that it makes sense to try to improve that further. And so those are patients who presented with inoperable disease or who were operable disease and were still node positive at surgery. So looking at that specific high-risk group to randomize to TDM1 or trastuzumab deruxtecan. And this is a global study that is just being activated. We just learned that the phase 3 metastatic study that was comparing trastuzumab deruxtecan to TDM1, DESTINY-Breast03, reported positive results, improvement of progression-free survival, and so we're very interested in, of course, how much better was it in terms of efficacy, but also what about the safety? That original study, those were heavily pretreated patients. We know that over time, as we treat patients, ILD starts to be more of a problem. So there's still the hope that maybe as we move it into earlier lines of therapy, we won't have the ILD, but we'll see. And this is being presented at ESMO. So it's very, very exciting data. So I do think, what Catherine has really changed our therapy for HER2 positive early breast cancer. I think it really compels us to do neoadjuvant therapy and to at least neoadjuvant trastuzumab with chemotherapy at the very least. And that, for patients who don't enjoy that PCR, then TDM1 is a consideration. And it's great to hear that the biosimilar TDM1 is now going to be available for patients and oncologists to consider in India. So I thank you for your attention and look forward to discussions. stop sharing.
Thank you, Dr. Gay, for the very nice talk. And I believe all the questions and the discussion will happen in the context of the panel discussion to be moderated by Dr. Raja. So, Dr. Raja, can we invite you to start the panel discussion?
Yeah, thank you, Dr. Sudeep. Thank you so much for letting us in now. And I do have the privilege of moderating this extremely accomplished oncologist. We heard the wonderful talk from Professor Gair. I think really a path-breaking, trial, Catherine, and which has in turn led to many other ideas on how do we really try to fill up that delta, increase the survival up and up and up. I have very, very illustrious panel. I have Dr. Ajay Bapna, Dr. Bishwajit Dupashi, Dr. Chirag Desai, Dr. Devendra Pal, and Dr. Niti Raisda, and Dr. Sandeep Ganguly, and Dr. Sajan Raj Prohit. All are medical oncologists, and Dr. Sanjay Sharma and Dr. Vinay Deshmane, our surgical oncologists. So I'm very delighted to be with you all. I'll share my slides. Please allow me to share my slides. So the panel discussion is on, in the next 40 minutes or so. Panel discussion is on decision making in the early breast cancer HER2 positive setting, and we had a scintillating lecture from Professor Gair. He covered the entire gamut of how things have evolved and how things are, can I say, all bases are getting covered in HER2 in the early breast cancer space. We are not going to leave anything undone, kind of an approach that has been displayed here. That's so gratifying to see just in 1 or 2 decades how a disease with a dismal prognosis has changed ever since trastuzumab was presented to us by Professor Slavin, and that has been a revolutionary change. And here is a case. Based on the case, we will initiate the discussion. We have a 38-year-old premenopausal lady. She is a professor by profession, and she has a painless lump recently detected, and there is no significant family history, no medical comorbidities, in a good shape. She had a 3 into 3.5 centimeter primary, and she has a single mobile non-tender 1 centimeter axillary lymph node. And the investigations, of course, confirmed the suspicion, and the FNAC was positive in the biopsy, confirmed that it is an IDC, high grade, and is ER negative, TR negative, and HER2 3+, and no disease elsewhere. So that's the clinical and investigatory finding. Therefore, we have this patient who is basically T2N1 and M0, and an early breast cancer who is HER2 positive and ER and PR negative. So that's where we are. So I just want to know from our colleagues first, and then we will go to Professor Gair. How does the MDT look at this from various points of view? Whether surgery is considered, whether neoadjuvant systemic therapy is considered, or any other thoughts are brought in here. I will ask my medical oncologist, and I will ask the surgical oncologist for the opinion. I'll begin with my dear colleague and dear friend, Dr. Ajay. Ajay, yes, sir. What would your MDT swing to, and what would you personally think about this patient? I say it's an operable disease, and very good performance status. What is your take?
My take on for this patient is that the patient is highly educated. So she must be aware about, what are the newer thing happening in the treatment of breast cancer, especially HER2 positive breast cancer. The current guidelines that more than 2 centimeter HER2 positive tumor patient should be counseled for the neoadjuvant chemotherapy. And at the same time, she should be counseled that surgery could be an option in the operable breast cancer, but we will never know that, whether you are having a resistant clone in your breast cancer. That can only be known if we are giving you the neoadjuvant chemotherapy And at the end of surgery, it will be perhaps better to know whether you are harboring a resistant disease.
Okay, so that's an approach that you have finally brought about, that the patient in front is important, her profession, her
Yes.
absorption, and how she is going to cope up. That's very important. I totally agree with you, Dr. Niti. I know you are practicing in one of the major metropolis in the city, so I would presume that you would have, and that you one of the most cosmopolitan metropolis in the city. So therefore, I would presume that the clientele would be well informed. Let's assume that. So, what are your thoughts? How will you?
In our MDT, I mean, I think most of us will reach to a consensus that we need neoadjuvant treatment on this lady, and probably identify the tumor with a radiopaque surgical clip, wherever possible breast, and of course, if possible, the axilla to be marked. We normally will use dual anti-HER2 therapy wherever feasible, when cost allows, or at least, chemo in conjunction with trastuzumab. Assess after generally 6 cycles, and then go with breast conservation surgery.
So I'll turn to my surgical oncologist, Dr. Vinay. Vinay is there. Dr. Vinay Deshmane is one of our eminent surgical oncologists from Mumbai. Vinay, what will be your take on in your MDT? What will you tell Dr. Vinay, if your medical oncologists are too keen to get into neoadjuvant chemotherapy? What will you tell?
Well, very rightly has been pointed out that it has to be discussed with the patient. This is a 3.5 centimeter tumor with a lymph node in the axilla. One will discuss neoadjuvant treatment, especially the tumor and the breast, the size. If the patient does insist on having surgery up front, there is cost which is involved. There's also cost involved in radiology, in clipping the tumors and things, which also plays a huge role in the way our patients think, even the upper middle classes. So cost is a major constraint, but as rightly again pointed out, most patients are aware, at least in my practice, most patients are actually aware about Herceptin, not so much about pertuzumab at the moment, but trastuzumab definitely. And it is always discussed. But there are patients who turn around and say, well, I just don't want a breast conservation. I want a mastectomy. When you are not absolutely certain of survival advantage long term, are you then justified in pushing the patient for neoadjuvant chemotherapy? And I think this is the question which actually pop up in the clinic. And as Professor Graham really pointed out, it becomes individualization. And you are treating an individual patient who's discussing this with you, but it has to be discussed.
Perfect. I think it's fair point to bring a counterpoint. I will also turn to my another very dear friend and a very senior colleague, surgeon, Dr. Sanjay. Points just to, adding on to what Dr. Vinay has presented. What is the cost difference when we involve the clips? And number two, are there some problems with the clips? And are there some complications of clip? Is pain is an issue? Can you address on that particular points, and what will be your advice to your MDT for Sanjay? You have to unmute yourself, sir. Sir, you are muted, Dr. Sanjay.
Yeah, okay. Can you hear me now?
Yes, Dr. Sanjay.
Okay, I totally agree with what Vinay said and Niti as well as Rajat said. Especially in a case which has got a high-grade lesion like this with an axillary node and lesion as big as 3.5 centimeter. Obviously, a lot of things matter, as clearly mentioned by Vinay after discussing. And if I was to tell the patient that what should you, because most of the time in India, majority of patients are really keen to save the breast. So we would definitely, in that event, I will give a neoadjuvant chemotherapy followed by the surgery. And the question that you asked for the clip, yes, it is expensive, all right. But now we have got some indigenous technique to put some cheaper clips. So it is, comes handy, and that's our game. And majority of time, at least for a large node negative, then this patient has an aggressive disease, I would give an SCT followed by surgery at a later date.
Raja, can I ask one?
Yeah, sure, Ajay.
Dr. Sanjay sir, how much the clip cost? Actually, we are medical oncologists, probably are not aware.
No, the imported case costs almost about say 500 or 700 bucks, or maybe sometime more than $1,000. But we have not got indigenous techniques to do that, and that costs you less than 100 bucks, or even cheaper than that. So, it's not difficult to now do that. Since we have a large number of patients, about 10% patient only, as I mentioned, can afford those imported clips that we use. But as I said, we have indigenized it, and now we are happy with the results with putting those clips.
Perfect. Thank you, sir. Thanks for the inputs. And then, let me move on. And then, let's say which patient we will consider for preoperative systemic therapy. Is there a consensus? This is the paper from Professor Cardoza, and then this is in 2019, and we also have the American Society of Breast Surgeons recommendation in 2017, and talks about tumor more than 2 centimeter, and also talks about node positive disease. That's basically the agreed consensus. So, Dr. Biswajit, this is another paper in JCO 21. Dr. Sonia Pemaz has presented a possible algorithm that a tumor less than 2 centimeter may be operated as long as it's clinically negative, and the tumor more than 2 centimeter or clinically node positive can be taken through the algorithm of neoadjuvant chemotherapy, surgery, and so on and so forth. So, do you think this is an acceptable algorithm in our setting, on your setting? Dr. Biswajit? You have to unmute yourself, Dr. Biswajit.
John.
Can you hear me?
Yes.
Sorry. So, if the T is less than 2 centimeter, generally we use the APT protocol. So we go for afferent surgery. Though I see here that the algorithm you could use the neoadjuvant protocol, but I don't know whether less than 2 centimeter we will be over treating many patients if we follow this protocol. So my take still on less than 2 centimeter would be to do the APT protocol rather than doing the neoadjuvant treatment.
So I think we have talked. I mean, I have specific. This algorithm is more than 2 centimeter or not possible.
Okay. For the more. Okay.
Just take it. And I will go to Dr. Chirag. Decision on some of the possible which will influence our decision making in choosing what happens with these trastuzumab-based therapies. This paper was from in the Oncologist by Professor Dahl, 2017, and he has kind of teased out the risk factors that would finally influence the outcome in patients who receive early breast cancer, HER2 positive, and the trastuzumab-based therapy offered. Still, you have these subsets that are probably going to do poorly. What is your take, and how would you choose your neoadjuvant patient, Dr. Chirag?
So, I mean, it is actually discussed by the previous panelists. So, I don't think age will be the major consideration. Age is merely a number. We should look at the comorbidities. That is first thing. But otherwise, any T2 or any node positive patient, we should recommend neoadjuvant chemotherapy. If you look at the JCO consensus paper published in the last year about neoadjuvant therapy, T1C is a gray area right now. And my personal idea is, as Dr. Biswajit said, for T1C, I will be using APT-like regimen. But some of the T1C patients by APT, we might be under-treating, and we need good biomarkers to identify those patients.
We heard the opinions from both our surgeons. So I'm going to ask one of our medical oncologists, Dr. Ganguly, Dr. Sandeep Ganguly, do you think that neoadjuvant chemotherapy improves your breast conservation rate? What is your take?
Yes, to some extent.
And
ideally, the surgeon should be the best person to say, but I think in our practice, for some cases, there is an improvement in the breast conservation rate. As per my surgical form, I don't know what here they will say.
To ask Dr. Vinay. Dr. Vinay, are we now fully convinced that in patients who are fully consented, fully agreeing, neoadjuvant chemotherapy can be a tool for improving the breast conservation. Do you agree on that, Robin?
Oh, most definitely. Been using it liberally for many years.
You have been using that approximately. Thank you.
Yeah.
So now let's turn to our patient, and this patient, let's say, has chosen neoadjuvant chemotherapy. Now, my dilemma is that, okay, neoadjuvant chemotherapy is chosen, and we heard the excellent presentation from Professor Gair, and also we have, based on the previous several data, now single antibody therapy or dual antibody therapy. Is that completely settled or not based on the PCRs and so on and so forth? Dr. Sajan, can you comment why should we choose a dual antibody therapy, and would that definitely give us the desired price of increased PCR? Are you convinced on that?
Yes, sir. Whenever I have a chance to use dual inhibition, I always prefer to go for dual inhibition because with complete pathological response rates being much higher in the dual blockage, I would be offering this to my patients. And the professor also shown this in his own data that dual blockage is better than using only trastuzumab.
Totally agreed. Now, the dual blockade, it has increased PCR, so we have already we are aware of the data. So, but then if I can slightly push and ask whether that increased PCR has been converted into an increased EFS or OS, whether the subsets have shown that from the dual antibody. We'll come to that. So, I'll ask Dr. Devender. Dr. Devender, this is the data Professor Gair showed us. This is the Lancet publication by Professor Cortazar. This is PCR is equal to EFS. And particularly if you see the HER2 positive and ER negative, highest PCR, and the PCR converts to EFS. And this, again, this is actually a pooled study of about 12 trials and more than 11,000, actually 12,000 patients. And you see that the patient who has a total PCR versus no PCR, and not only the EFS, the OAS is also improved from the data of nearly 12,000 patients. So I think that question is fully settled. So, but my dilemma is this: neoadjuvant therapy with the dual anti-HER2 improves, but more chemotherapy, higher PCR rate. Has this Neosphere and Trafina data has been converted into a higher OAS or not? That's the question I want to ask. Dr. Devender, you can answer that, but I'm going to ask Professor Charles Gair this question. So you can answer this.
Sir, as Professor Charles has also shown in his slides, also a few more slides, that we have data for IDFS, but not concrete evidence for OS, but from the pooled analysis which you have shown, sir, Professor Charles has also shown, over a period of time, we are getting a lot more encouraging results, and we are more confident that yes, the PCR results are accumulating into the OS and EFS benefit over a period of time.
Yeah, totally agreed. So I'm going to turn to Professor Charles Gair to answer this question. Before that, I'm presenting this paper from Dr. Lara Spring. This is a pathological complete response after neoadjuvant chemotherapy, and this is a comprehensive meta-analysis published in 2020. And this has put together 52 papers, 52 of 3,209 publications, 27,000 patients. And this has looked at both triple negative and HER2 positive patients. But the bottom line is PCR is equal to higher EFS and higher OS. Particularly, this was again shown by Dr. Dattatreya that in HER2 positive EBC, we have the EFS advantage and the OS advantage of, with PCR, we reach a OS percentage of as high as 95. That's what. So I would like to ask him, sir, the double antibody, or if we keep on escalating and if we really achieve that surrogate marker of higher and higher PCR, will that reliably convert into OS? So that's the question. So please, sir.
I think that's why I did want to present the affinity data, because, in a sense, in the US, we got the approval for pertuzumab initially just as neoadjuvant therapy based on PCR. There was 5 years where you could not give pertuzumab to an early breast cancer patient in the US and have it covered by insurance companies unless you did it as neoadjuvant therapy. So this is why we were very interested in the affinity data, to see if is there evidence that the dual antibodies result in long-term improvement in invasive disease-free survival, which it did confirm. The prognosis, though, is so good that, if you say, well, I need more than IDFS, I need OS, I don't know that will ever be something that we can demonstrate because patients do so well with trastuzumab. But I do think that certainly, if you're in an adjuvant setting where you have node-positive disease, I think that absolute 4 or 5%, if you can afford it, in IDFS is worth the therapy. We're clearly, extrapolating then to the neoadjuvant setting that the big thing is if you're looking at limited resources and you're thinking, okay, I have 3 HER2 targeted drugs, trastuzumab, pertuzumab, TDM1, and there's expense with all of them. If I have to just lean on 2, which would be the most important 2? And I think without question, it's trastuzumab and then TDM1. I think pertuzumab has become the least important of the 3 because of Catherine.
It's a great insight, Professor. I think that's a great point you have made. And so therefore, okay, we all agreed on neoadjuvant therapy, and then we'll just look at what will be the backbone that everyone wants. Let's ask a couple of my colleagues. Ajay, what is your backbone chemotherapy that you want? Neoadjuvant is everybody agreed. Okay.
So the backbone of the chemotherapy is certainly without anthracycline based on the TRAIN-2 data. And if we look at the current version of the NCCN, the anthracyclines have been removed from the preferred option. So now the option is between only TCH and TCHP as per the affordability of the patient, because TCH will give us the pathological response rate of only 40%, while TCHP will give around 65 to 70%. So this information need to be shared with the patient, but no anthracycline, and non-anthracycline is my preferred choice.
Okay, so I think you have really gone ahead, and you have already kind of seen the slide set, but I'll come to that. We'll talk about anthracycline in a minute. So this is we all know this data was presented by Dr. Dattatreya and also Professor. We know the Neosphere PCR rates and the Trifina PCR. The question to Dr. Niti is that, with the introduction of, the discussion about the TRAIN-2 and all, what is your preferred chemotherapy backbone, anthracycline or not?
So as Dr. Ajay pointed out, I would prefer wherever feasible a dual anti-HER2, and TCHP would be my preferred choice. In other situation, TCH, I would normally avoid anthracycline in most of the situation. Very rarely when there's a large tumor burden and there are economic constraints, I would possibly start with AC and follow with TH.
Okay. But I have some questions on this TRAIN-2 study. If you look at the number of cycles that have gone, so I'm going to turn to Dr. Bishwajit. Bishwajit, look at the randomization arms in the TRAIN-2, and essentially we need to end up giving around 3 plus 6 TCHP, and that's a long journey with TCHP. That's what I think. Whereas the other arm is 3 FEC, followed by 6 TCHP. So and then of course surgery and everything else follows. Just on that point, the TRAIN-2 data was presented by Professor, and he clearly argued that anthracyclines did not make the dent both in the the total population or even in subset of ERPR positive, ERPR negative. Everywhere they were almost equal. There is nothing to choose, and all the subgroups were in favor of the non-anthracycline arm. Almost all the subgroup except maybe the node negative, the slight oddity, but otherwise everything was in favor of. And as he also pointed out, finally the EFS and the OS did not make the cut to say that anthracycline has got anything else to do. So Bishwajit, now are you convinced that anthracycline should be away in the neoadjuvant setting?
So in my practice, the number of patients who receive pertuzumab is almost 1%. So if you use pertuzumab, then I would use only the taxane. But if I use only trastuzumab, then I have other issues of 6 months of trastuzumab, because many of my patients cannot afford more than 6 months of trastuzumab. So in that subset of patients, I would definitely go with anthracycline and give 6 months of trastuzumab. If we are able to give 1 year of trastuzumab, then we will give anthracycline. That's what I practice at my center. The question about whether we can completely omit anthracycline, again, as you said, I also always have this query that there are too many number of cycles, too many paclitaxel, 9 cycles of paclitaxel is very difficult to deliver. With neuropathy, after 6 cycles, 3 more additional cycles of paclitaxel is always difficult to give. So I am still not very convinced that whether we can really omit the anthracyclines in the locally advanced tumors. Probably in the lower tumors, maybe you could avoid. That's my take on the anthracyclines.
Okay, that's a very beautiful point. I think you are working in a large community center, and so the patient profile is more challenging. So your point is very valid that you can't give pertuzumab for all your patients, and you think anthracycline has got a lot of it. We'll take that. But I'm going to turn to Dr. Chirag. I mean, here is the long-term safety data from TRAIN 2, and what essentially it captures is that the left ventricular ejection fraction decline in patients who have been exposed to anthracycline. Percentage is presented here, but what is more important is in the long-term follow-up, the left ventricular ejection fraction decline did not improve in more than 1/3 of those patients, even with adequate cardiac support and off therapy, whatever. So, Dr. Chirag bhai, what do you think? You are going to drop anthracycline from your neoadjuvant program if cost is not a consideration, or cost is a consideration?
So if the cost is not a consideration, definitely I will drop anthracycline from the neoadjuvant program. And if I look both at the TRIFINA data as well as TRAIN 2 data, I think I will give 6 cycles of TCHP and not more than 6 cycles of TCHP as neoadjuvant therapy. If you look at patients who do not afford pertuzumab, if I extrapolate from the data of VCRG 006 adjuvant therapy in node positive as well as node negative patient, anthracycline doesn't make a dent in the overall outcome of the patient. But still, in neoadjuvant therapy, I will not be very willing to go without anthracycline. I will still give anthracycline with PH.
Thank you, Chirag bhai. I mean, I think we gave 6 cycles of for this patient.
Can I raise one point?
Yeah, sorry?
Can I raise one point?
Yeah, yes. Go ahead, please.
Yeah. So, another point against using anthracycline is that we are unnecessarily delaying the anti-HER2 therapy in these patients.
Okay. So that's also important. Dr. Sajan Raj Purohit, I mean, we have treated this patient with TCH, and then the patient has been operated. And I present to you 2 scenarios in which there is, scenario 1 is that there is a residual cancer, invasive cancer, 1 centimeter in the primary tumor, and axillary node is negative. And scenario 2 is pathological complete response in both primary and axillary. So we'll come to scenario 1, and this is what we have. Now, we heard the excellent presentation and compelling data set from A. What will be your approach in this patient who has been treated with, let us say, whatever best choice all our med-oncs wanted as a preoperative neoadjuvant, and now we have a residual disease? Dr. Sajan, what do you want to do?
So amongst the choices which we have, so my preferred choice will be to switch over to TDM1 for 14 cycles.
TDM1 for 14 cycles. So you are basing your choice based on the delta survival curves that he has preferred, that he has presented. So my question to you, Dr. Sajan, is that in your mind, the TDM1 data, Catherine data that he has presented, is it strong enough that it is completely practice changing in our setup, Dr. Sajan?
Yes, I agree. So I strongly feel that it is a practice changing data for us.
Dr. Sandeep Ganguly, you also agree that it is a complete practice changing?
Yes, it's definitely practice changing. The 3-year results are encouraging. So if a patient can afford, we should offer those.
Okay, so let's look at the data set. This is the professor presented that, and this is in essence the most important outcome of this data set, that the survival, invasive disease-free survival at 16 months, the delta is around 11%, and that is from 77 to 88. So he presented that the 77 was even better than what was anticipated, but still then this could score much higher, and the hazard ratio is very, very impressive, 0.5. And also this, these patients, 18% of them had trastuzumab, pertuzumab, but a big chunk of them had trastuzumab alone. So I'm going to present a conceptual question to Professor Gabe. Professor, since we have this TDM1 in what we call as a strong quarterback or pinch hitter later on, and you also alluded to the pertuzumab dilemma, can we now say that we can omit pertuzumab and rely on TDM1 as a follow-up post-op? Professor Charles Gabe.
Yeah, I think that is absolutely justifiable in any kind of resource-restrained situation. There is the reality that TDM1 has more toxicity than just continuation of the antibody. So the patients who don't get the PCR, it's the patients that you think, well, if I drop my antibody, drop to one antibody and my PCR rate is a little bit lower, I'm going to expose more patients to TDM1. It did have more side effects, so there are those trade-off issues that for me, I still like to try to get PCR as high as possible. I just because I think in terms of, for tolerability in the back end, I'd rather just keep my antibodies going than switch to TDM1. But I have to acknowledge that there is a cost and resource thing. As I said earlier, I do think that graph that you showed, if you could go back up your slide, I wanted to make one point with the Kaplan-Meier. See, this is the Kaplan-Meier, the previous one, I think. There. Oh. You'd show right there. See, and this is where I think this patient, if you go down and look at the YPT1C, which is what she would be, she's got, her hazard ratio is 0.34. Again, these things overlap, but sometimes with that smaller residual, there can be a sense of, well, do I really need it? How well do they do with the trastuzumab? If you look at that, the 3-year IDFS with trastuzumab for that cohort was 76%, improved to 92%. That's where I think that really compels me to make sure even that group that had a pretty good response still gets TDM1, because that's where I think the forest plots can be helpful when you're thinking about an individual patient. If you go over to the far right column and look at the 3-year IDFS. Nope, I'm trying to live on. Yeah, you can see what I'm talking about there. The 75.9% going up to 91.9%. That is a big absolute delta, and this was a pretty substantial group. So I think it's this is a group that's why. When they get smaller, okay, then I'm talking about smaller absolute differences. But this is why I do think when you're having individual talks with patients, resource constraint, and also I think 14 cycles are critical. 14 cycles was chosen for design regulatory purposes. I think studies that would be of interest would be, well, do I need 14? What can I do with 7? How much would I lose? There's lots of follow-up studies that I think can be done, but I would sure want to give this patient some amount of TDM1.
Thank you, Professor. And Dr. Devender, The question to you is, Professor presented a compelling argument that TDM1 contributes much more in the larger scheme of things in early breast cancer than the pertuzumab. And we also are very, very familiar, but he presented some very interesting follow-up on the affinity data at 6 years. It was interesting to see that the hormone receptor versus that it didn't hold up, and hormone receptors also benefited, but not positive. Other than that, one would say that the pertuzumab is not doing much. So in that situation, Dr. Devendra, can we say that it is now okay to omit pertuzumab in the neoadjuvant setting and put the money on TDM1?
You're asking about the neoadjuvant setting?
In the neoadjuvant setting, based on what just said and based on what we have learned from affinity also.
So in the neoadjuvant setting,
you can hazard your own guess.
Yes, it is very difficult to say about this, but still, sir, I'll say the primary role of pertuzumab remains in the neoadjuvant setting, not in the adjuvant setting, because in the just the benefit of 2 to 3% of PFS, that also in a node positive disease, it is very hard to tell the adjuvant impact of this drug. So I think in the adjuvant setting, pertuzumab will not stay. Now we have TDM1, so I don't think it's
Dr. Niti, do you have a thought on this? I'm now just showing the Kathleen data in which the adjuvant TDM1 can be kind of TDM1 plus pertuzumab plus pertuzumab, and that analysis so on. I'm trying to put the pertuzumab in context here, Dr. Niti, your point. Dr. Niti, you are with us? Dr. Ajay?
Yeah, so adding the pertuzumab in the neoadjuvant setting, it is helping us in converting more than 2/3 of the patient for the breast conservation surgery. I think we should not forget that.
We should not forget that. Okay.
Yeah.
Fine, fair enough. So, but I mean, on the other hand, we didn't look at neratinib for a long time. But then in the larger context of things, even though we are very, very skeptical about neratinib availability and diarrhea, so on and so forth, but that seems to be, if you look at the delta of the XGNet, I mean, that seems to be significant in the end, and that seems that it can fit into this particular scheme. So, my question to Dr. Chirag is this. This is the proposed strategy. We are now going to summarize, presented in Annals of Oncology 2020, like what you exactly said. T1C, it is still a cat on the wall, but T1A and B surgery and anything above that, T2, N1, etc., with the neoadjuvant pathway, residual disease, TDM1, and neratinib thrown into it. So, what is your take on this, Chirag bhai?
So I agree with everything except the last thing. Neratinib, I'm not too keen on giving in spite of good data of XGNet study. There are a couple of reasons for that, and maybe Professor Gayas can throw some more light on that. During the conduct of a neratinib study, the sponsor was changed twice, from Vyas to Pfizer and from Pfizer to Puma, and the study design was changed a couple of times. If you look at any study of HER2 positive disease, the outcome is better with escalating HER2 positive study in hormone receptor negative patients. While this was an outlier, possibly an outlier, where the outcome was better with hormone positive patients. So I am not very keen to accept the data of neratinib. So that's my take on that.
Pose the question to Professor Gair. He also presented this COMPASS HER2 escalation, de-escalation strategy, and you would immediately see that we are trying to fit into tucatinib, looking at the excellent outcome in the metastatic setting with tucatinib. So my point is this: after a good neoadjuvant therapy, you achieve a PCR or no PCR, get a TDM1, and then follow it up with either neratinib or tucatinib. Is that kind of a completing the picture as of now, Professor Gair? What is your take on this?
I mean, I think the small molecule TKIs do seem to have better CNS activity than the antibodies do and the ADCs. And so that if that's still the unmet need, and those are the particularly disappointing patients, that have isolated CNS recurrence, because you feel like, we probably cured their systemic disease, but didn't take care of the brain, that she had the occult brain disease. So that's why I think that is still the unmet need, and the excitement about tucatinib, is that it clearly has generated the most impressive disease we've ever seen against HER2-positive brain metastases. I mean, phase 3 survival data in patients with brain mets is just incredible. It is also much better tolerated than both neratinib and lapatinib, and it combines pretty easily with TDM1. You don't seem to have a lot, and there doesn't seem to be much in the way of synergistic toxicity. So the phase 2 combination studies that have been done really were showing pretty good tolerability, enough to warrant, taking it into the early setting. You could certainly can think about more of a sequential approach. If tucatinib's not available, if you have patients who presented with large disease, who did not have a great response, who were ER positive, you can imagine patients, younger woman, there you might think, well, should I at least see how she tolerates neratinib based on extenet? So I don't use the neratinib very often at all, but I do think there would be patients where I would probably be inclined to at least see how she tolerates it.
Thank you, Professor. And this is going to be my last panel question, but I'm going to direct it to you, Anvi. Can you give us a sense of what's cooking? There is this neoadjuvant immunotherapy being fitted into the HER2. We know the New England Journal publication of pembrolizumab in the TNBC setting, triple negative setting, which has now already kind of changed our practice. But what about HER2 space and the neoadjuvant immunotherapy, and then again the CDK4/6 inhibitors? Can you give a sense of what is evolving in these, if you have an early wind of these things, if you can tell us, Professor?
I think the neoadjuvant space with checkpoint inhibitors, it was a space that I think was really courageous to try to. Again, I just feel like where we are now with our dual antibodies and the chemo, there's just not a lot of space to add more to that group. And, they did report out with the atezolizumab study, it didn't seem to increase PCR rates appreciably, and they had that imbalance in death. So I don't see that checkpoint inhibitors are probably going to find their way into early HER2 positive breast cancer. We are looking at it in NRG BR004 first line, adding to trastuzumab and pertuzumab, since there seems to be that signal of immune effectiveness that seems to eventually go away for most patients. Would a checkpoint inhibitor augment that? But I think it's unlikely it's going to be early disease. The thing that we're also trying to sort out are the CDK4/6 inhibitors, because that interesting data, that shows they do augment HER2 directed therapy, and they're already for ER positive. So what we do in that triple positive patient population, I think is going to continue to evolve. And this is more about, I think we need to move past, are they HER2 positive? It's like, okay, are they HER2 positive? Yes, but are they HER2 enriched? Are they luminal? Are they, are we talking, heterogeneity? I think we're going to have to see how we do with tucatinib and how we do with the 8201 to see how much room there is for further improvement by adding the CDK4/6 inhibitors, because, chronic therapy with some toxicities, but, it's certainly, these are things that we are being studied, that I think it remains a very interesting space. And I think we're getting close to where we really should be able to offer each patient presenting with HER2 positive early breast cancer a high likelihood of cure. We just have to get smarter about selecting and who can we back off on, who do we need to intensify. And this is where I think Catherine has sort of shown us this ability to assess your standard therapy activity, look for evidence of that resistance, and then target the resistant disease.
Sir, you talked about in your escalation and de-escalation, you talked about the biological heterogeneity and also talked about hetero-enriched populations. We are really focusing on that in the metastatic setting, hetero-enriched population, so on and so forth. My question is, do you routinely do the ERBB level? Do you do the liquid? Do you do the mRNA levels? And how do you identify those apart from the other markers like if your hormone receptor negative, those clinical markers, but do you do the molecular markers to identify your to enriched population and then try to act on that? What do you do in the clinic really?
Clinically, I'm not doing it routinely yet. I still think that's part of the research because we don't have proof that doing that test will give me a different direction in my therapy. So I think I think it's coming, I mean, it's when we're doing we're doing a neoadjuvant study targeting HER2 enriched patients. So we're just using the MammaPrint assay to identify HER2 positive who are, HER2 enriched, looking at the dual antibodies with the checkpoint inhibitor, giving up chemo completely. So again, I said I don't think it's going to get in there unless you can show you can completely get rid of chemotherapy. You can do that, then it can crowd in, but added to, I don't think so. And we've just started the study and it's very active. Those three antibodies are very active together. We're kind of excited about it. So I think it's an area that's going to continue to evolve, clearly.
Maybe we should do the MammaPrint and then take it. Totally agreed, Professor. And we can, I turn it over. I request, you had some questions, Professor. Otherwise, I'm turning it over to the Zydus. Thank you so much for this opportunity. Thanks for all the panelists. And Mr. Ashish, over to you.
Thank you so much, sir. We at Zydus sincerely thank all the eminent group of oncologists who joined us today evening for this scientific symposium. I thank Dr. Charles for this great session today and through his talk showing the future direction in the HER2 positive early breast cancer. We are hopeful his so many insights from Catherine data, which he shared today, will be helpful to clinicians in India in improving outcomes for early breast cancer HER2 positive patients. My sincere thanks to our chairperson for evening, Dr. Sudeep Gupta and Dr. Advani for their presence. I thank Dr. Raja to you for bringing so many insights from real-world clinical practice through your moderation today. I thank all the panelists for today evening for their presence and contributing in building consensus on key areas in HER2 positive patients. A final thanks to all our virtual delegates. Over 300 virtual delegates joined us today evening from across the country. A last comment, which is a great information for India as well. A team of scientists actually who developed Ujvira were also instrumental in developing the first DNA plasmid COVID vaccine of bird, ZyCoV-D, which is now approved for 12 years and above in India. So this great team of scientists is actually giving a lot of solutions to the country and the globe. We hope and wish safety for all of you, and thank you for your contribution in improving cancer care in India. We thank you for your presence today evening. Stay safe and good night. Thank you so much, everyone.